we'll have like a debate on cochlear implants. Essentially about like issues with cochlear implants, side effects, and yeah, everything we do is available on biomedical.com, so go check out the website. Everything is open source. All the code should be on the page itself. So check it out. And don't forget to provide your feedback. So you're here for a treat. We will be talking about issues with cochlear implants, migration and extrusion, MRI considerations. Yes, we won't be able to do MRI scans, which might be a big problem in some cases. Bacterial meningitis. There you go. Chronic infections, intracochlear fibrosis, and ossification. Ossification is something to do with the bones. Sensory, neurological effects, tinnitus, balance and vertigo, taste disturbances, chronic pain, facial nerve issues. Yeah, there's quite a few. But yeah, we'll have a bot reviewing those. We have a bunch of sources, Mayo Clinic, some papers, cochlear implant MRI, safety guidelines, pediatric specific risk. In children, long-term complications are influenced by physical growth. Changes in skull shape as a child matures can impact the placement and performance of the device. Conversely, yeah, I did my PhD on cochlear implants, and I didn't even think about this one. When you implant in children, well, what happens to the implant as the head, the skull, and the hearing system grows? Yeah, we did a bunch of stuff on hearing. We have these two simulators, one on the cochlear implant of how the sound is being processed, and another on the insertion. So it's like a surgical simulator. So the one with the sound processing, you obviously need to give it permission for your microphone. You can select your cochlea, linear shape or spiral. Well, when it's inserted, when it's implanted, it is in this spiral shape. You can select your number of electrodes. It doesn't actually changes the frequency spectrum, whatever, but it does change the visualization. Normally you have 20 something electrodes, 21, 22. Select your color, of course. And obviously rainbow is the best color ever. Yeah, so you can see how it works, how lower frequency sounds activate how different frequency sounds activate different parts of the cochlear implant, different electrodes along the cochlear implant. Yeah, and you can see it in the spiral shape. It's kind of harder to see what's going on. Yeah, we had a custom prompt for it. Issues and side effects and complications of cochlear implants, compare the risk of nerve injury versus the benefits of better hearing, discuss the potential impact on patients' daily quality of life, obviously the most important one, structure the argument of formal exchange between surgeon and the patient. So it should be essentially a discussion between the surgeon and the patient. Yeah, flat battery of the device, essentially turning you into profoundly deaf individual again. So we'll mention that. Well, the bots will mention that as well. And ethical questions like deaf community culture, disruption, animal research, and locked into one company that controls your implant.
Imagine undergoing a complex surgery that, successfully cures your profound deafness, but leaves you literally unable to taste your favorite food.
Yeah, or a surgery that restores the voices of your loved ones, but suddenly makes the room spin violently when you just try to stand up.
Or permanently ties your primary senses to a rechargeable battery pack.
Right, exactly. Is that a staggering medical miracle? Or, is it an entirely new kind of disability? That is the exact tension we are wrestling with today.
It really is. We tend to view medical interventions as binary, right? You break a bone, a doctor puts it in a cast, the bone heals, and the story is over.
Yeah, it's fixed.
Exactly. But a cochlear implant is not a cast. It is a lifelong, highly unpredictable marriage between human tissue and a machine. It is. And to set the baseline here for the discussion, A cochlear implant is an electronic medical device that physically bypasses damaged hair cells in the inner ear. It basically takes acoustic sound, turns it into electrical signals, and directly stimulates the auditory nerve.
Right.
So it has fundamentally transformed the landscape of sensory neural hearing loss. But today, we are asking a very specific question. When you weigh the undeniable, documented clinical benefits of restoring a human sense against the realities of nerve injuries, chronic vestibular complications, and, well, a lifetime of device dependency, does cochlear implantation represent an unequivocal enhancement to a patient's daily quality of life?
That is the core issue.
Right. And I am taking the perspective of the surgeon and the clinician here. From my standpoint, the meticulous evolution of our surgical techniques and the profound audiological benefits far outweigh what are fundamentally manageable risks.
And I'll be looking at this strictly through the lens of the patient. From that perspective, clinical success metrics like, passing a hearing test in a sterile, soundproof booth, they completely gloss over the severe daily disruptions to quality of life. The patient is the one who actually goes home with the unpredictable biological and technological complications.
Well, I think we have to start by acknowledging the sheer magnitude of what this device accomplishes, though. I mean, we are talking about the only medical intervention in human history capable of fully restoring a lost human sense.
Sure, the technology is impressive.
It's unprecedented. And as a clinician, I don't pretend the surgery is without risks. Take bacterial meningitis, for example.
Right? A major concern.
Exactly. Children with cochlear implants, especially those with pre-existing anatomic abnormalities in their inner ear, they have a statistically higher risk of contracting pneumococcal meningitis. Because, well, we are creating a pathway into the inner ear.
A literal hole in the skull.
Basically, yes. But we don't just cross our fingers and hope for the best. We manage this with really rigorous protocols. We mandate specific heavy-hitting vaccines like the PCV13 and PPSV23.
The alphabet soup of vaccines.
Yeah, it sounds like it, but they are highly targeted pneumococcal vaccines administered weeks before surgery. We build a biological fortress against those specific bacteria. And because we standardize that prevention, the risk becomes incredibly small.
Okay, but
Let me just finish this thought. When you look at the payoff, deaf children developing normal academic and linguistic pacing, adults regaining their careers and social lives, it is a triumph.
But see, framing it purely as a manageable risk is a uniquely clinical luxury. You're talking about managing the risk of a fatal infection, which is great, obviously.
Thank you.
But what about the permanent chronic burdens that aren't fatal, but deeply degrade the lived experience? We celebrate the restoration of hearing, but we rarely talk to the patient about what is being permanently sacrificed to get it.
Sacrificed? I think that's a strong word.
Is it? Approximately 10% of these patients will experience chronic pain or discomfort at the implant site for the rest of their lives. 10%.
Well, chronic discomfort can mean a lot of things.
We are looking at a permanent toll that includes sudden taste disturbances, violent vertigo, and the looming psychological threat that the machine embedded in your skull might just, fail. It is an incredibly heavy trade-off. It's not some frictionless magical cure just because you vaccinated the meningitis risk away.
Okay, then let's break down that trade-off by looking precisely at what happens during the surgery. Because to place the electrode array into the cochlea, a surgeon has to navigate a microscopic, incredibly delicate neighborhood of anatomy in the middle ear.
Right. And the most vulnerable resident of that neighborhood is the Chorda Tympani nerve, the CTN.
Yes, the CTN.
This is where the patient's lived experience immediately diverges from the clinical success story. The CTN is basically a bare wire running right through the middle ear space. It branches off the main facial nerve and carries the sensory fibers responsible for taste on the front 2/3 of your tongue.
It does, yes.
But the biological design here is terribly exposed. As it passes through the tympanic cavity, literally right between the tiny ear bones, the malleus and the incus, it lacks any protective bony covering at all.
Right, it is essentially suspended in midair within the cavity.
Exactly, suspended in midair. And because it's just hanging there, exposed, it is frequently stretched, scraped, or even entirely sacrificed just to get the surgical drill close to the cochlea.
Well, sacrificed makes it sound malicious, but yes, it can be injured.
And when that nerve is injured, the patient wakes up with hypojugia, a severe loss of taste, or worse, dysesthesia.
Which is rare, but it happens.
They aren't just experiencing a lack of flavor, right? They are experiencing constant metallic tastes or a burning, tingling sensation on their tongue every single time they try to eat.
Right, but...
And that's to say nothing of the adjacent facial nerve. If the implant's electrical signals misfire, they can jump to the facial nerve, causing involuntary facial twitching. So you go in for hearing loss and you wake up with a burning tongue and a twitching eye.
Wait, hold on. I have to jump in there because we need to weigh these outcomes proportionately. I mean, sacrificing a fraction of taste sensation on one side of the tongue Not a remarkably small biological toll to pay for the ability to hear your child say, "I love you"?
It's easy to say that when it's not your tongue.
We are talking about a metallic taste versus the reversal of total deafness. Come on. Beyond that, the idea that surgeons are just recklessly drilling through nerves is an incredibly outdated picture.
I didn't say recklessly, but it happens.
Our precision has evolved immensely, though. We aren't using brute force anymore. In the past, yes, surgeons performed a cochleostomy, literally drilling a new hole through the hard lateral wall of the bone to force the electrode in.
Which was highly traumatic.
It was. But today, the standard is around window insertion. We actually sneak the electrode through the ear's natural, membrane-covered back door.
Which is certainly less traumatic than a bone drill, I'll grant you that.
It drastically reduces trauma, and we pair that natural entry point with incredibly advanced, flexible electrode arrays.
Right.
Some of these arrays are 31.5 millimeters long, but they are as thin as a human hair. They're literally designed to curl naturally with the spiral of the cochlea without scraping the walls.
Okay, but
And as for the facial twitching, we use continuous intraoperative monitoring now.
always?
Standard practice. The entire time the patient is asleep, we are watching the facial nerve's electrical activity on a monitor in real time. If we get even slightly too close, the monitor alerts us.
Okay, I hear the enthusiasm for the technology, but calling the loss of taste a small biological toll is very easy for the surgeon to say because you aren't the one sitting at the dinner table dealing with a constant metallic burning on your tongue every day.
I understand it's uncomfortable.
It's more than uncomfortable. Minimizing the loss of one sense to save another is a purely clinical rationalization. To the patient, losing the joy of their favorite food is a profound daily emotional disruption. It is a constant physical reminder of the surgical trauma.
I think trauma is a bit...
And while round window insertions and flexible arrays sound incredibly elegant, you know the human body doesn't like foreign objects. The body's immune system will often attack the electrode materials, creating intracochlear fibrosis.
Scar tissue, yes.
Right. That scar tissue chokes out the delicate structures inside the ear, permanently destroying whatever tiny bit of natural residual hearing the patient had before the surgery.
Look, it is true that inserting a foreign body induces a foreign body response. Biology is biology. Fibrosis is an ongoing challenge, but we are actively trying to mitigate it with steroid-eluting electrodes.
Trying to, yes.
But the trauma, if we're calling it that, doesn't end when the incision heals and the nerve pain settles. The real test begins when the patient goes home, the device is turned on, and they are thrust into a completely altered sensory environment.
Absolutely.
And a massive part of that environment is how the implant interacts with tinnitus.
Which is another massive point of friction.
But often a really positive one. Look, tinnitus, that constant maddening ringing or buzzing in the ears, it's already present in about 80% of patients with profound hearing loss before they ever sit in my surgical chair.
Right, the brain is starved for sound.
Exactly. Their brain is starved for sound, so it creates phantom noise. And the implant actually serves as a powerful therapeutic tool here. The clinical data shows that 60% of these patients experience a significant drop in their tinnitus functional index scores after getting the implant.
60%.
Because we are feeding the auditory nerve real signals again, the brain actually stops screaming. And what's even more fascinating is the phenomenon of residual inhibition.
Where the tinnitus stays quiet even when the device is off?
Exactly. 80% of patients who see improvement find that their tinnitus remains suppressed for hours, even after they take the external processor off to go to sleep.
Wow.
Yeah, it proves the implant isn't just a physical speaker, you know? It is inducing positive neuroplasticity. It is actively rewiring the central neuronal networks in the brain to calm that phantom noise.
That is the absolute best case scenario, though. But look at the darker reality of the data that magically doesn't make it into the surgical consultation brochures.
It's all in the literature.
Yes, some patients see their tinnitus drop, but 20% of patients report the sudden emergence of entirely new tinnitus immediately following the surgery.
Well, 20% is...
Imagine undergoing an invasive skull surgery to fix your hearing and coming out with a constant, inescapable siren in your ear that you literally never had before.
It is a known risk. Furthermore,
Nearly half of all patients experience a temporary, sometimes violent, aggravation of the ringing they already had.
but it usually stabilizes.
Usually isn't a comfort when you're the one lying awake at night for 6 months. And, we haven't even touched on the collateral damage to the vestibular system yet.
The balance center?
Right. The inner ear isn't just for hearing, it's our body's spirit level. Right next to the hearing organ is the saccule, a tiny fluid-filled sac lined with hair cells that tells your brain which way is up and senses gravity.
The Anatomy 101, yes.
Well, when you thread a foreign electrode into the scala tympani, the fluid channel of the cochlea, you physically displace the fluid and risk bumping that delicate sac. Up to 75% of patients experience some form of vestibular impairment or vertigo post-surgery.
75% is a broad net.
But it's real. The room is spinning, they lose postural stability, they can't drive, they can't walk unassisted, they can't work. It drastically derails their independence.
I completely acknowledge the severity of vertigo. It is debilitating. But we have to ask a critical physiological question here. Is that vertigo truly and solely caused by the surgical intrusion of the electrode?
What else would it be?
Well, does it primarily stem from pre-existing inner ear malformations that made the patient's anatomy a ticking time bomb before I ever made an incision?
What do you mean by a ticking time bomb?
I mean, many patients who require cochlear implants have severe genetic or anatomical anomalies. For instance, enlarged vestibular aqueducts.
Okay.
The vestibular aqueduct is a bony canal that protects a fluid-filled duct in the inner ear. If a patient is born with an enlarged one, it's like a pressure release valve that's stuck open.
Right.
Any minor shift in pressure, even just hitting their head during a fall, can trigger catastrophic balance issues and hearing loss. Or consider incomplete partition type 2 anomalies, where the cochlea didn't fold into its usual neat 2.5 turns during fetal development.
Sure, those conditions exist.
They do, and these patients are inherently predisposed to severe balance problems. It is incredibly difficult to untangle the surgical trauma from the underlying pathology that caused their deafness in the first place.
I hear that. But honestly, whether the vertigo was triggered by the electrode fluid displacement or an underlying anatomical anomaly, the lived reality for the patient on a Tuesday morning is exactly the same. The floor is spinning and they cannot stand up.
Fair point. The symptom is the symptom, regardless of the precise mechanical trigger.
Right. But let's step outside the biology for a moment, too. Beyond the nerve damage and the vertigo, we really need to examine the immense, permanent technological burdens.
The hardware.
Yes. We are talking about what it means to live your daily life entirely reliant on an external implanted machine. There's a profound psychological trauma tied to device dependency.
You're referring to the failure rates.
I am. The clinical data shows device failure rates between 5 and 12%. There are soft failures where the implant doesn't completely die, but the patient suddenly experiences intermittent static, bizarre sound distortion, or software glitches.
Right, which require reprogramming.
Or worse. And then there are hard failures. The internal computer chip just dies. The lights go out. The only fix is to put the patient back under anesthesia, cut them open again, and surgically extract and replace the entire internal unit.
Look, device failures are devastating, I won't argue that, but they represent a small minority of cases, and our diagnostic abilities to detect soft failures early by measuring impedance telemetry.
Impedance telemetry.
Yeah, basically checking the electrical resistance of each individual electrode contact. That technology has improved dramatically. We can catch issues before they become hard failures.
But even when the device works perfectly, the daily practical burden is relentless. Just think about the battery.
It's a rechargeable system.
To a clinician or an engineer, a battery is just a lithium-ion power source. To a patient, a dead battery is a sudden, jarring plunge into total isolation.
Well,
Imagine your eyesight being tied to a Wi-Fi connection. You're having a deep emotional conversation with your spouse, or you're walking through a busy intersection and suddenly the router resets.
that's a bit dramatic.
Is it? You are plunged into total, instantaneous darkness. That's exactly what a dead battery feels like to a cochlear implant user.
It is an interruption, yes, but it takes 10 seconds to swap a battery.
It's an enforced dual existence. You have to remove the external processor to swim. You have to take it off to shower. You have to remove it to sleep while those batteries charge. Every single night, the light switch is flipped off.
To sleep peacefully.
But if your child cries in the next room or a smoke alarm goes off, you cannot hear it. That creates a stark vulnerability that naturally hearing people simply do not possess.
I understand that anxiety.
And the burden extends to broader medical care, too. If a patient with a Beha track system or an older nucleus model suddenly needs a high-resolution 3 Tesla MRI to diagnose a stroke or check for a tumor, they can't just fly it into the machine.
Because of the magnetic field, right?
Exactly. The MRI is a massive electromagnet, and the implant relies on an internal magnet sitting under the scalp to hold the external processor in place. If you put that patient in a 3T MRI, the machine's magnetic field will violently torque the internal magnet, potentially tearing it right out of the bone.
Which is why there are protocols.
For years, patients have had to undergo an actual surgical procedure under local anesthesia just to have their implant's magnet temporarily sliced out of their head, get the MRI, and then have it surgically sewn back in.
Okay, I have to stop you there because you are painting a static picture of a technology that is actually evolving at breakneck speed. You are absolutely right about the older models, but we are constantly engineering away the frictions of the past.
Are we?
Yes. Newer implant models like the Nucleus Profile Plus and the OSIA OSI 300 are specifically designed to be MRI-conditional. We've redesigned the internal magnets so they can freely rotate within their titanium casings.
Oh, I read about those.
Exactly. This allows a patient to safely undergo a powerful 3 Tesla MRI with the internal magnet safely left in place. No surgery required whatsoever.
Well, that's a massive relief for new patients, obviously. But there are hundreds of thousands of people walking around with older models who are still subject to those limitations today.
True. But look at where the science is heading. Our advancements aren't just in making a better magnet, you know? We are utilizing deep genetic and biological research to understand the very nature of the deafness we are trying to cure.
How so?
For example, clinical researchers are heavily relying on zebrafish
Wait, why zebrafish?
because they remarkably share about 70% of our human genome, but with one massive biological advantage. The hair cells in their inner ears can naturally regenerate.
Oh, wow.
Yeah. Humans lose those delicate inner ear hair cells to loud noise or genetics, and they are gone forever. But by studying how zebrafish regenerate them, especially when we model specific human genetic conditions like Waardenburg syndrome, which causes profound hearing loss and changes in pigmentation, we are unlocking the underlying mechanisms of deafness.
So, biological repair.
Exactly. We aren't just trying to build a better battery. We are trying to tailor future biological interventions. The goal is to eventually move past the hardware altogether. So yes, batteries die, and it is jarring. But I have to ask the ultimate question here. Does the temporary vulnerability of removing a processor for a 10-minute shower truly negate the 16 hours of vibrant, restored communication, the enjoyment of music, and the social integration a patient enjoys every single day?
No, it doesn't negate it, but it deeply complicates it. Because while the science of zebrafish and regenerating cells is a beautiful future, right now, today, the hardware is what patients are dealing with. And that hardware comes with another massive ethical and practical caveat:
Which is?
corporate lock-in.
The proprietary ecosystems.
Exactly. Once you are implanted, you are essentially locked into one specific medical device company for the rest of your life. Your biological sense of hearing is inextricably tied to a corporate product line.
Well, they are specialized devices.
But if another company develops a vastly superior external processor 5 years down the road, you can't use it. Your internal array only talks to their specific hardware. You are a captive consumer in a way that just doesn't exist anywhere else in medicine.
That is the reality of FDA-regulated proprietary bioengineering, unfortunately. The arrays and processors have to be highly specialized to be safe.
And it's not just the corporate aspect either. There is a deep cultural and ethical conversation happening within the deaf community.
I was wondering if we'd touch on that.
We have to. For decades, deafness has been treated purely as a medical deficit, a broken machine that needs an engineering fix. But for many, deafness with a capital D is a rich linguistic and cultural identity centered around sign language.
Right.
The aggressive push for early childhood implantation often forces the patient to straddle two worlds. They rely on a machine to function in the hearing world, but if the battery dies, they are thrust into silence without necessarily having the foundation of deaf culture or sign language to fall back on.
That is a tough position.
The implant forces them into a liminal space, often feeling fully integrated into neither world.
I hear you. I think that highlights the incredible complexity of what we are trying to achieve. When I look at cochlear implantation, I fully acknowledge the biological friction. Pushing a foreign body into the delicate fluid of the cochlea carries unavoidable risks of fibrosis, taste disturbance via the Chorda tympani, and yes, severe vestibular impacts.
It is a heavy toll.
It requires rigorous preoperative protocols, heavy vaccination, and microscopic surgical precision. However, when I look at the trajectory of the technology, the rotating magnets that allow for MRIs, the flexible arrays protecting the cochlear walls, and the phenomenon of residual inhibition actually rewiring the brain to alleviate tinnitus, the ability to physically restore a lost sense remains a staggering medical triumph.
It is a triumph of engineering, yes.
It is a calculated risk that for the vast majority of my patients overwhelmingly pays off in human connection.
And the patient perspective doesn't deny that human connection at all, but it insists that the clinical data is only half the story.
Right.
The daily reality involves managing chronic nerve pain, unpredictable loss of taste, the terrifying vertigo that strips away their physical independence, and the profound psychological vulnerability of sudden device malfunctions. The cochlear implant is an undeniable engineering marvel, but it is an incredibly complex, lifelong physical and emotional burden. It is not the clean, frictionless cure that a 95% surgical success rate implies.
What this entire discussion underscores, I think, is the absolute necessity of examining these advancements through dual lenses. You literally cannot look at the audiogram without looking at the dinner table.
Absolutely. And there's vastly more to explore in the source material regarding central neuroplasticity, how the brain actually adapts its neural networks to electrical stimulation, and what those zebrafish might eventually teach us about regenerating our own biology.
We will leave it to our listeners to weigh the profound, life-altering benefits of restored hearing against the tangible daily costs of the hardware. To circle back to our beginning, perhaps the goal of medicine isn't just to install a light switch, but to truly understand what it feels like for the patient to live in a house where the wiring is constantly adapting to the electricity. Until next time.